the global impact of diabetes on the Muslim majority countries are there. And we all know the impact in the three main regions, Africa, MENA, and Southeast Asia, and where the three groups for the data are coming. Among the type 1, from the Dar Global Survey 2020, as presented already, my colleague Dr. Hasnain divided the group into 3, and we wanted to look into the data analysis to see what are the regional differences in the 3 classes or categories which we defined based on the 50 to 70 side, that's those below 50%, those from 50 to 70%, and those above 70%. And we classified them into the low frequency, medium frequency, and large frequency. As rightly pointed out by my colleagues, we know that there have been these studies, 3 major ones over the last 2 decades. And as we see here, the important part to learn is that from EpiDiar to Dar MENA and to the Dar Global Survey, we see something is changing. And that's something for type 1 is important. There is some decrease in the age where people are ready to fast. In the type 2, we see there have been so many new molecules and the medications available, which much less risk of hypoglycemia. The major, most important complication we as well as our patients and their families worry when they are planning to fast. At the same time, there have been a change in the availability of the modern insulins, but that is not the only factor that younger age are fasting. Important thing to note here on this slide is that the global type 1 population, the mean age was 28, whereas for the medium fasting, the mean age was 21. It suggests indirectly from the small data set available that maybe the average age of patients with type 1 diabetes in this category is lower compared to the global survey. Then many individuals with type 1 intend to fast despite previously high risk of complications, and we noted that mean number of days fasted were 23 to 27 in the data collected. Already pointed out, as I said, they were highest intention countries, those with the medium intention where the data I am presenting. These were Egypt, UAE, UK, Iraq, and India. And here we see trying to comprehend the data, what is the difference? And as you can see, among the type 1, in the EpiDiar time, only 43% were intending to fast. And being one of the authors of the EpiDiar, in the time frame where that study was collected, we knew that even most of the patients at that time were not using analog insulin. And number 2, the physicians taking care of these patients had classified and categorized that type 1 should not fast. And I was one of the experts in the field. We used to say type 1 should not fast. So the intention by the patients, 43%. But as we see the time moved and the education moved and the guidelines came, we see with the setup of the DAR and IDF guidelines, 76% in Dar MENA. In the global type 1 survey, we found 69%, and in the medium fasting group, we had 63%. So I don't see a big difference in that data, which is global for type 1, 69% as compared to 63% in the group where I'm presenting. About the patients who fasted for more than 15 days, again, you can see not much difference. 72%, 80%, and 82%. So it has increased compared to Dar MENA, but among the global population and the medium fasting population, the number of days fasted for more than 15 days was not very different. That means the reason could not be as per the conjecture we are exposing here, could not be that they were sicker or they were having more hypoglycemia or something like that. Those who fasted 30 days again, 26.8 in the global survey as opposed to medium fasting 30 days, 30%. And the mean number of days fasting again 23 and 22, and the breaking of the fasting percentage 59 versus 51. All this data suggests that as we compare with the global population for type 1 in the DAR survey, we don't see much difference in the medium fasting compared to the global population. So it doesn't appear to be the reason that it is the patient type or the patient category. There may be other factors which my colleagues have already pointed out. Among the comorbidities which we usually consider would be one of the limitations for the patient not to fast. As you can see here, the duration of diabetes, 11 years in the global surveys, and I just pointed out, the age was lower as well as the duration of diabetes is lower in the medium fasting category. But in terms of the comorbidities, again, 7.8 and 11.2, but here is 9.38. And as we move forward, I thought let's compare not only type 1 for the global population and the medium fasting, let's compare with type 2 as well, because we see what is the big difference. And as you can see from the data available, distinctly our type 1 population is different because the intention to the fast is lower, the number of days fasted is lower, and the breaking of the fast is much higher, both in the global data as well as in the medium fasting group. But the number of days fasted, 26 versus 23 and 22. So all these point out that as we see in the type 2 as well, patients on multiple daily insulin therapy, which is obviously the case with type 1, their intention is low for the reason they have experienced hypoglycemia, they're afraid of hypoglycemia. Their physicians are more careful, and as my Dr. Jamal pointed out, they go for safety and prevention. So my conclusion here is that the global prevalence of diabetes is increasing, but we need greater need for practical guidelines for people with diabetes who seek to fast. Although several studies in the past decade have demonstrated that people with type 1 and type 2 fast in high numbers, many people that fast do so with comorbidities and complications, and risk stratification is an essential step. Greater research is needed to fully characterize fasting preferences in people with diabetes during Ramadan. Thank you very much, and I'll stop here.